I'm a medical graduate of a university founded in 1457. They don't have MOC over there. They do have federalism and many other things that lead us to follow guidelines and practice good medicine. And the important thing here is to realize the history, I think, is what I'm trying to emphasize, of where this all came from, and particularly where it's going. It's all about the money. This is an example of the first certification we probably all had to go through. I refer to the certification industrial complex. It's big business. The American Heart Association not only makes me be a provider, but a PALS provider and an ACLS provider. But by God, I'm a physician and I know all this stuff anyway. But every 2 years, you're supposed to go somewhere for 4 to 6 hours, sit there, review all this stuff again and again, every 2 years, to get that little stamp of approval because somebody requires it at your place of employment. And I'm an employed physician, and someone in our industrial complex decided that we all need this. The nurses need that one, but I need all three if I'm going to do what I do and do it well. So I subject myself to this involuntary action and go through this every 2 years and waste a good deal of my time. It's usually my Saturday. I don't do this like the pilots do during working hours. I get to go and do this on my free time. Aren't I a nice guy? And what do I learn? This is the summary pretty much of the whole ACLS process. It used to be ABC and now it's CAB, and breathing is pretty much, well, optional. And I have to laugh like you because I did my PhD in resuscitation, resuscitology, and I know it seems in my profession as a physician, well, breathing is my second favorite thing right after the circulation, I'll admit that. But it is very important, and these are only guidelines that were designed for the population at large so people would actually do it on the street. And, you know, mouth-to-mouth breathing and the AIDS of AIDS, that all fell apart. And so it's been recycled and regenerated, and now it's a one-slide summary that I give you there. That's pretty much what it's all about. But let's talk about certifications. 100 years ago, there were no licenses or certifications of any kind. These were things that were introduced to protect, quote, to protect the public, but also to limit the influx of people into the marketplace so we could have a sound financial future. And this whole business first started with medical students and foreign medical graduates. I am a foreign medical graduate. And the FSMB, does not represent the state medical boards. It uses them to verify their importance in medicine in this day and age. They actually pay for medical board non-physicians to travel to their meetings to give it that imprimatur that it actually is something. It is a 501c6 corporation, a nonprofit, and unlike Al Capone, we'll never be able to kill them because they don't pay taxes. And the FSMB, they're 2 years behind in filing their IRS 990 forms as a matter of practice to hide the information that is there that we may be able to use when dealing with our state medical boards. And in Ohio, we were the first state. They tried their MOL, and we got on that job. Ken and I became very active very early, and we exposed the fact that here in Ohio, our state medical board, and probably in every state there's a potential for that, is very prosecutorial because of the number of lawyers embedded in that system. And in Ohio, they pride themselves as being the best medical board because they have the highest rate of physician prosecutions or persecutions, the word choice is yours, of all states in the union of their size at 5.85 prosecutions per 1,000 licenses. And so they're very ingrained in that. But in the 60s, the AMA came up with this system of validating physician practice in so much as they came up with the CME concept, the AMA PRA, Physicians Recognition Award. We started to need some sort of document so we could hang it on the wall or show some bureaucrat that we're doing our job. And that's the essence of the certification industrial complex. Bean counters need beans to count. They can't look at you and see if you're a good physician or not. They need some sort of validation. And AMA was the strong horse in the 60s. But now, as you know, they've gone from 75% physician representation to about 15%. And it is my very hope that the AAPS will emerge in the future as the strong hope, as the representative of working physicians. And I think fighting MOC and MOL is one way to gain the membership we need and to protect the profession from the dangers down the road. Thank you. In 2000, the switch to board certification as a 10-year cycle thing came on. I'm going to go into a little more detail about that. In 2010, the FSMB came out with their MOL concept. And to say this about the FSMB, they make their money off of the USMLE tests. They started testing foreigners coming in and medical students, and now they're a $40 million a year testing organization. But I get back to that 501c6 membership organization. They have no penny listed in membership fees from anyone as a membership organization. And I suspect if someone at the IRS had a half a brain, they'd look into some of these nonprofits and find out how profitable they are and how little they do for the population at large. I found this to be a very revealing slide. The amount of administrators that have grown in the medical industry versus the relatively flat growth of physicians. I mean, 20, 30 years ago, you had a hospital, you had a CEO, that was pretty much it. Now you've got 10 CEOs and CFOs, and you know, they have all these acronyms for the various things. And that's what's costing medicine so much. It's not the doctors prescribing things or the patients needing care. It's the fact that we have this governmental bureaucracy, the hospital bureaucracy, and now the certification industrial complex that wants to crawl into our pockets. And if we look at the numbers, over 375,000 specialists, this is from 2010, from the ABMS, this is their own slide, I've stolen it, I'm afraid to say. They're saying that half of the doctors in the country are currently certified and in the MOC program. Now is the time to stop this. It is not even a majority, it's only half of the doctors, and those are the ones with the 10-year cycle certificates that are actually in MOC. They've reviewed grandfathers, and less than 1% of grandfathers have ever participated in this MOC, and I'll get back to that in a little bit. But these are all from their numbers. They're saying, we're going to be the strong horse. The AMA is declining. CME is no longer important. We're going to make our own CME, and we're going to make you pay for it in a major way. But what is certification? It's millions for nothing. The Good Housekeeping seal, on the other hand, that has a little bit of value. If you buy something with a Good Housekeeping seal and it doesn't work or it's a problem, they're required to give you your money back. The rest of this is just smoke and mirrors. There is nothing in the certificate that makes you a better doctor. You get certified because you are one of us, one of our striving colleagues who finds nothing in any challenge to conquer that and move forward. We're the hardest workers there are. We're from the cream of the crop when we go to med school, and we've never stopped working. That's why we are as good as we are, and that's why we get certified, and it has nothing to do with being better because you are certified. But it's about lifelong learning and not lifelong certification. And the MOC, the concept is they want you to regurgitate that textbook of whatever specialty you're in, which is basic knowledge. And next week, I'm going to go to an internal medicine board review because after 30 years of anesthesia, I don't think there's anything there I need to learn. Again, I work at a teaching institution. I work with residents every day. And for someone to tell me what I need to learn and feel that they have a better idea doing that, well, I would have to send them off to the loony bin because I'm afraid we all know better what we need to know. The essence of certification, and Milton Friedman was an economist, he stated, the pressure on the legislator to license an occupation rarely comes from the members of the public. On the contrary, the pressure invariably comes from the occupation itself. We are dealing with academicians who possibly see patients 2 to 5 hours a week and spend most of their time administrating something. They are administrators, and they need to justify their existence, and they justify that because education is a big business. We heard $250,000 of debt is routine for medical students, and it's a horrendous sum. And I only found out at the state medical meeting a few weeks ago that over 1,000 medical students in the United States, medical students, graduates, and one was the valedictorian from the Ohio State program in Toledo, didn't find a residency slot because now we have more students graduating than we have medical slots in residency. And perhaps residency training under Obamacare will be the next hurdle for people to try to worm their way in to even become a doctor after spending the fortune as a medical student. But let's go back and look at what this recertification business is all about. And I'm going to show you a couple papers from the ABMS and the ABIM. The ABIM drives this. Again, Internal medicine is oftentimes primarily physicians in private practice offices. There may be growth in medicine in terms of new concepts or new things to learn, but it all comes back to physiology and the bacteria and the viruses and the things that are out there, and very little really has changed in those things. It's about all the ancillary testing, the medications that we give patients that are driven from the pharmacy. There's all this big business out there that wants to sell their products, and they create industries, and the only way they can sell them to us is if they make us learn their programs. But at any rate, this is the chronology. In '70, the ABMS endorsed the concept of recertification, and they found that it failed. They couldn't get people to voluntarily recertify, so in 2000, they pretty much moved forward, and they said that they were going to, a program of continuous recertification came into reality. And this whole paper I'm going to go into, it's from Dr. Kimball and Duffy. These are big cheeses at the ABIM, and this is their program. They vary it. It looks a little different for every specialty, so I'm going to try and stay generic in many ways as best I can, but I will go into some details relative to anesthesiology. The goal is to provide documentation so that unwitting external agents can make money in the process, and they make good money. The CME industry for physicians was a $350 million industry in 2009, and CME was a $2.5 billion industry in 2005. So the concept of the MOC is to take control of the CME that's out there that is relatively expensive and take control of it for the benefit of these educational agencies, typically the specialty organizations. For me, it would be the American Society of Anesthesiology as opposed to the American Board of Anesthesiology. The boards only sell tests for big money. And now they're marketing the educational component, which all of our societies have been doing for decades, and they're giving it their imprimer of MOC as a distinct classification to make that money flow to get their support, so that it's not just the FSMB and the AB and the boards moving to push this upon us, but getting our national societies of all of our specialties to fall in behind them. And I can say this, I've tried to write many papers in many journals, and it's almost virtually impossible to get anything published in a specialty society because they see the big cha-ching of this MOC. And it's, as Dr. Crispin said, it's not the vast majority of physicians that are out there pushing this. It's very small educational elite who really don't see patients, who are substantiating their existence by pushing these programs on the working physicians of America. So voluntary recertification failed. They documented that there was a continual decline in grandfathers recertifying when they instituted this from 3,355 in 74 to 1,400 as time went on. They needed to do something else because it failed. And this was their plan. Will decrease despite of strenuous efforts to make the process more relevant. They linked it to the American College of Physicians Medical Knowledge Self-Assessment programs, and they said they were going to charge low fees. Well, let's get you in the door. We'll charge some small fees perhaps in the beginning, but even at this point in time, they are not small any longer. So the answer was to force everyone to be conscripted in this. Recertification at that time in a subspecialty such as cardiology or gastroenterology will not require the maintenance of an active internal medicine certificate. So they're going to pit various subspecialists, try to gain their support. You guys will just have to do your specialty recertification. You won't have to get the general internal medicine one. But some of them did. And I'm pointing out geriatric medicine because we will see in a few minutes how important that will play in the rest of this assessment. So they said that everybody, they've been pushing for the members of the ABMS, the ABIM, all of the boards, that everyone on these boards should be recertified in order to remain active as a high-level animal in this. And yet, what do we find? Well, this is a picture of Christine Castle, and we find that she's certified in 1979, valid indefinitely, never recertified in internal medicine, and twice in geriatrics recertified, even though the data I was showing you, she was one of the authors of that paper, of that ABIM protocol that said geriatricians would need to get their basic certificate here, and she never did. So these people are hypocrites, quite frankly. And this is the data pertinent to Dr. Chowdhury. He goes by Hank Chowdhury, that's easier for me to say. He certified in 1996 once and never recertified. So right now and this is from the ABIM's website. I've captured it there. This is their data. So the leader of the FSMB, we should all go out and do all this stuff, but, well, it doesn't apply to me. And he's not the only one. This is our new, quote, president of the ABMS. This is Lois Margaret Nora. She was very active in recertification. She did it once in 1987 and never again. And this is how it's going to be presented on the ABMS websites, should you choose to look up a doctor and see if they're certified or not. And you will find that if you don't enroll in this MOC, this continuous MOC program, even if you're certified, which she is and valid indefinitely, you are not meeting the MOC requirements. So it's no longer going to be about board certification. It's going to be, are you a MOC compliant doctor, whether you're a grandfather, an aunt, an uncle, it doesn't really matter. You're going to have to buy into this program or they're going to list you as being a bad doctor. This is a paper that recently came out, and I was afforded for the first time to publish an editorial regarding the MOL, MOC issue, and these are the numbers of these various organizations certified in general medicine. These are their raw numbers, and these are the percents of recertification, and the highest is 20%. And you see that these are the leaders of these companies, they're companies, and they don't recertify, but we should. And that's pretty much the essence of that paper. I think it's worth reading if you take the time. And this, when we talk about the science behind recertification, I like to say there's a very large lack of science behind it. This, again, is from the American Board of Medical Specialties, the Associate Vice President, the Executive Vice President, and they tried to do a meta-analysis of all the papers out there substantiating the importance of board certification, which, again, I certified twice. I'm board certified. I teach residents. I advocate that they make that leap, that not just on-the-job training, but learn the science and become a scientist and make that step, but only do it once. And when I list my certification, I say board certified, and I put the years, and that's it. Certified is past tense. If you're certified, you're certified. Why do you have to do it again? I did it the second time for academic reasons. I was pressured by my chair. I did it for that reason, and I will say now I'm never going to do it again. But the conclusions of this ABMS-supported, funded, founded, written study was few published studies use research methods appropriate for the research question, and among the screen studies, more than half support an association. And I say unto you, day always follows night, night always follows day. The association is 100%, but they're not causal in any way. I mean, the night takes 3 months in Alaska in December, and they have nothing, they're not causal in any way. But the studies that they do, these 5%, they support an association. They don't prove an association, they document that it might be there. So there are no systematic reviews. This was between 1996 and 1999, so it's a little old. There have been some studies since then, but it's the same thing, regurgitating old data in a way, using retrospective data review by and large. And we know as scientists, analysis of retrospective data is highly, highly, highly influenced to bias in the way you set it up. And when you have, and these papers are invariably authored by employees of the ABMS and or subcontractor companies to go and do their data search and, you know, ghost authorship. This is the kind of stuff you're dealing with, and they're very effective at going to Congress and selling to Congress how important all this stuff is. So we see that there's an overwhelming influence of ABMS in these so-called scientific studies, and if you review some of them, and there have been people who have actually sat down and went through this, you will find that the science is very, well, it's not there. To the point where the ABMS, in their question and answer page on the internet today, you will be able to read ABMS states in 2012, fact, recognizes that regardless of the profession, whether it is healthcare, law enforcement, education, or accounting, there is no certification that guarantees performance or positive outcomes. It's a sham, but we should all buy it. Now, Going through the history a little bit more, in 2003, the ABIM hired the Gallup Corporation to go out and do a survey. Everyone's heard of the Gallup Corporation. A Gallup poll is a very important thing. They pick the best people because they want to have their name on it. And I'm just going to go through just a couple questions to emphasize the fact that when they did this, they actually educated people about what the question was going to lead them in terms of answers. Now, after looking at this, I went out a year ago and asked 101 people coming into a Quickie Mart one question. When you seek a doctor out, why do you go to him and why do you stay with him? And of the 101 people, board certification never came up. So I could say to you, people don't. And if you go to your next family reunion, ask people, well, you know, what's board certification? And they'll be pressed hard to try to give you an answer. They won't know. The public does not know. So this is the first thing you have to do in interpreting this. But this is one of their questions, and this is the answers. And, you know, the question is your doctor, your primary care doctor, the doctor you go to, board certified? And 72% said, well, sure. And then the next question, they said, well, have you ever asked or checked or, you know, how do you know that he's board certified? Well, they didn't know. They just assumed that. And so they're building these questions as they went along, educating people to get the answers they wanted. And again, they asked them, you know, how frequently should physicians be evaluated? And they come up with these every 3 to 5 years seems to be the peak. But again, when they use this data, evaluated or tested, we're tested with every patient. All the people looking after me as an anesthesiologist, I'll show you in a slide in a moment, but the ABMS sells this then to the federal government, to Congress, that they are the only lords of certification. They are the ultimate reality in deciding and testing, and the public wants this. The public had no idea. Who else is watching? This is from the Ohio State Medical Board, one of their slides, except I added this down here for me as an anesthesiologist. There's plenty of people watching over us, waiting for us to trip up. Not of least mentioned are the trial lawyers, the families, the colleagues. There's so many layers of the Better Business Bureau, people out there watching after us if we trip up, if we're bad doctors. I can honestly say I don't know a bad doctor. And I have ENT surgeons, one guy does this, one guy does this, one guy does radical next, and they never do the other stuff. Why should they go and relearn that textbook of general knowledge every 5 or 10 years or whatever they're mandating? And why should any of us subscribe to a pre-focused program that some 12 guys behind a boardroom has decided we should regurgitate at 5 or 10 year intervals? I find that offensive. So I've tried to press the concept of regulatory capture as a new catchword for us in dealing with MOC and MOL. It occurs when special interest groups co-opt policymakers or political bodies, as regulatory agencies in particular, to further their own ends. And that's what's occurring. The FSMB is a company that sells tests. The ABMS is a company with 24 affiliates that sell tests. And they've colluded with our medical specialty societies on a national level to build this system of consumption. And if we don't stop it now, it will succeed. But nothing is inevitable. We need to go home. We need to talk to colleagues. And I'll tell you this, I'm standing here talking to a very friendly group, but I've stood up in Boston at an anesthesia meeting where one of these board members was giving a lecture on what we should expect to be doing soon for the MOC, and I got up and I raised 5 questions, and the crowd turned mean. If you go home to your medical societies and raise the appropriate questions, and they're easy to find in the AAPS journals, you will find colleagues standing up and fighting with you on this. And I have to hand it to Larry Huntoon, who took this to the New York State Medical Society, passed these resolutions, and at the first steps you will hear, it's not possible, it's all inevitable, there's nothing you can do about it. But when you stand up in a crowd of working physicians and say, what about this? The crowd will turn mean, and you will see how much anger is there. Now, this is from the FSMB's own files. These are the states, they're pilot states. Ohio was the first, and we're lucky because we were in Ohio, we caught it early, we knocked it down. It's not going to happen now, and I hope it never happens because we've made our colleagues aware. Dr. Kumar, who is going to speak here today, I think he, as the leader of the OSMA, the Medical Association, brought all the specialty societies together, and with 15,000 signatures told the state medical board, hell no, this won't fly, excuse my French. So we can make progress. We have to get together. In these states, already resolutions have been passed. We need to see that they happen in all. Maybe these are from Larry's files. You can find these on the AAPS Journal. If you want to make a resolution to take to your meta society, that's the first step in making an effective movement towards stopping this dilemma or this, well, this bad thing. And the states typically have the rights to legislate what you need for a license. And I would say this MOL, maintenance of licensure, I've been maintaining my license in Ohio since I think it's 1989, for decades. And there's always been the requirements of CME and fill out the forms, pay the money. There has been maintenance of licensure, and the FSMB has tried to capture that as their own entity to make that their money machine, as is the ABMS. And if we define these truths and expose these lies, it is very, very, very likely your colleagues will jump in and understand that. I remember the first year I went around at the societies and made my pitch against MOL, people listened to me, you know, everybody should be doing their boards, not a big deal. But when the MOL came around and said, now we're going to hook it to your license, now there's going to be a hitch in your giddy-up, people became aware very quickly, and the resolve to fight this was immense. And you must bring the message home that this is not about board certification anymore. This is about a continual conscripted subscription to the point where the ABMS would like you just to give them the credit card so they can charge you annually and send you the stuff. And this is a certain testimonial here of what the reality of this. One of my colleagues, on Sunday I spent 5 hours on the computer doing this thing, and it was free. CME is becoming cheaper. I can get all the CME I need for free just by reading the Journal of the Cleveland Clinic and doing the CME available there. I lecture, we can get our CME, it's not a problem, it's becoming cheaper. And that's one more reason why specialty societies are joining in with the boards to make programs that you can't get for free anymore. We're gonna put the price on it and you're gonna pay. So this person said, I did it, it was free, but then I had to pay $625 to get my MOC credits. CME is no longer enough. Now we have to get the MOC credits. Now I'm going to talk a little bit about my specialty society real quick because I'm an anesthesiologist. I will tell you, first of all, anesthesia is only 5% of all the physicians in the United States, and we paid 10% of all the MOC general revenue to the boards under the ABMS. So they will charge what they can. Pediatricians don't make much money. It might be cheaper, but you're going to see numbers that maybe will scare you because apparently I can afford to pay more. But at any rate, you know, these are the dues. These are the educational products, and the reality of this thing is that it's showing you that we are a dues membership paying society, and unlike the FSMB, we have a lot of dues. The FSMB has 0 dues as a membership society, and I hope the IRS will investigate these people. Of the non-dues operating revenue, you see that in 2008, there's been a significant growth from 7 million to 12 million in this publications, educations, and other things, and it's particularly relevant to the MOC phenomenon. So it's a money winner. And you see here, we were, as a society, we're very happy to get this money because we were in the red until this happened in 2008, and we are now a profitable organization again, and thank you to the boards. However, if you read this, this was from 2010. My board said that the ABA does not believe that the additional requirements for the MOC bonus, now this is the PQRS, the ABMS went to Congress and said, you know, our doctors are terrible, you need to be able to check up on them, we need this educational program, and we can give it to the country, but the PQRS, this is part of the ACA program, the PQRS MOC payment, and I'll get to that in a little bit, we were supposed to get paid if we enrolled in MOC, okay? And that this payment will not reimburse or justify the amount of expense that our members are going to have to do. So we're just not even going to worry about it. We're not going to become a provider organization. The trick being, of all the boards, and I'll move on down, first of all, under the PQRS, this is the index year. You'll get 0.5% if you're doing MOC and you do your PQRS, you fill out the forms, make the bean counters happy, you can get some more money that you wouldn't have gotten otherwise. In 2014, it's maintained, and then it goes, if you don't do MOC, first you get the bonus, then you get the penalty, and in 16, it's a minus 2%. And everybody got all upset about the sequester, but this is what the sequester is as well. Of the boards that have enrolled to be providers to even allow you to get the bonus, there were only 2, 4, 6, 8 of them who did that. Now me, you don't see anesthesia up there. My board said no, so I never would have even been able to get the bonuses, and I will always be subject to the penalties. So if one of your boards isn't listed here, or if you're an osteopath, you probably are listed here, you never even had a chance because the boards really didn't care. And that's another phenomenon I think that's very important to emphasize is many of the boards never wanted 10-year cycles. I have talked to 3 anesthesia board members who are on the ABA, and they said, no, we never wanted it. But in 2000, the bottom line was put up or shut up. Either you do the 10-year cycles or we're pulling your franchise. You won't be able to be an American Board of whatever. These are directly from the ABIM, American Board of Internal Medicine website, talking about continuous MOC, and I've highlighted some of this stuff for our benefit to go through because there's a lot of text. Certification, board certification is only an entry step into this continuous MOC process. You're going to do your boards so that you can become a subscriber to their continuous thing. Certification and MOC have been and continue to be an evolutionary process, and they can change it at a moment's whim. It is whatever they say it is, and they had been saying that if you went and took the board the test and got recertified in 2008, it would be good, and you were due to do it in 2010, it would be good to 2020. All of a sudden they changed their mind and said, no, it's only going to be good for 10 years. If you do it early, you won't get the extra years tacked on. You're only going to get 10 years from the day of certification. But now some people have gone and tried to recertify at the end of the 10 years, and there wasn't a date in February. They had to do it in March or April, but it expired in February, and suddenly they got kicked off of the hospital privileges because they weren't certified, and then they got certified a month later, but there was a problem, and now it takes 6 months to go through the accreditation process. This is a setup to hurt doctors, and I think part of it is under Obamacare, we would rather have nurse practitioners and PAs doing medical care, and why not? I mean, they can go to medical school cheaper, and they can do all this stuff, and it's all very simple anyway. I mean, Dr. Mom can do most of this stuff, and we won't have to pay so much. It's all about making it cheaper, but we're going to make the doctors pay. Okay, and it's about fulfilling our mission of the ABIM, and they're going to make the decisions to their financial needs. So what changes? Then we're going to start reporting whether you're certified or not, as well as that we're going to report whether you're enrolled in MOC, and we're going to put it out there. But I really don't care. I don't think patients even look at that stuff. I really don't. When you go to your family reunion, you talk to your relatives, and they won't know what board certification or MOC even is. So are you meeting the requirements or not? The next thing will be JCAH will then not only demand board certification, but demand that everyone's enrolled, and by Jove, all of a sudden we have the money gravy train rolling full-time for the ABMS. What does it cost? The ABIM says specialties range from $206 to $257 per year. Well, that's probably not true. Larry's doing a study right now. I can't wait to hear how much it costs when you start thinking about all the little things that you do. This is probably just for the test. There's a lot of other things, and in every specialty it's different. But I personally think if I count the dollars I spend to do MOC, if I were to do it, I would probably be in a 10-year period, at least in the $30,000 range, if not more. And depending on your specialty, if you sit down and count the MOC points and the practice improvement modules, you will find not only, and then bill for your time, because this is going to happen on your Saturday when you're supposed to be with your wife and kids. You can't take it off from your practice time. And the other thing I think that's real important about this practice improvement modules is I tend to think this is research on patients without consent. If you're going to start changing, one of the examples is reducing the hemoglobin AC levels in patients that are too high to make your practice better, to demonstrate that you're improving care. Well, if it's running high and you start to give more drugs to people, there's a risk that people will become hypoglycemic, and when George drives off the road in a hypoglycemic coma, that's not going to be good care. That's not going to be good for George, but it won't show up in the ABIM statistics because they really don't care about that. It's about the money. Well, what does this do? How does this benefit me? Well, you can earn your MOC points. Maybe they'll be good for CME too. Your states will still be requiring you to CME. So will you be able to do just this 50 CME, or do you need to do now 70 hours of whatever to do the MOC and the CME? This is whatever they say it is. It's 12 guys in a boardroom making decisions about what you need to do to remain as a doctor. This is for the grandfathers. If you're a grandfather, diplomats with a certification that is valid indefinitely will need to pass the MOC exam in their certification area by 2023. You got to do it. They're telling you right now there is no grandfather clause. Everybody is going to have to line up, pay the money, and do whatever we say, or we just say no. If the AMA dwindled away to 15%, I think if the ABMS becomes that onerous and physicians stand up like we have in Michigan and Ohio and New York and say, pass legislation excuse me, that prohibits anyone from requiring board certification or MOC as a contingency for privileges on a hospital, privileges or billing rights with an insurance company, I think we can stop this now. We must stop this now because it's a gravy train on a roll and they're making lots of money. They control the journal publications. We need to do this at the grassroots level. And like I said, I hope the AAPS can do this as a momentum-forming mission to gain all of our members as the new strong AAPS as the AMA was back in the 60s. And the ABIM, they are the leaders. They are generating all this stuff. They see that they can make it work. It will come to your specialty, whatever it is. That's all I'm trying to say. Then, in contrast to this, the ABIM, you may have read about this, choosing wisely. It's worth reading. It's ludicrous. They want every specialist society to come up with 5 things we should no longer do because it's a waste of money. And Christine Castle says, if we can get every doctor to quit doing 5 things that's costing too much money, we'll be able to pay for Obamacare because we'll save all this wasted money and be able to pay for the care that we need. And the joke of it is, so we will test patients less, but this is the same company that says we're going to test the pants off of all the doctors. And there's no proof, no validity either that this testing of doctors does anything. So we have the needless testing for patients, which is essentially let's give less care to patients, to the point where recently a Cochrane study has documented that the yearly physical isn't worth the money. I mean, what is it we can do that's good for patients anymore when everyone's trying to downgrade knowledge levels to that of physician assistants and nurse practitioners, algorithms that they can just let roll. There's no more individualization of patient care based on patient needs, based on clear medical sound judgment. It's all going to be algorithmic in nature. And this is the standard contract. This is the pathology boards. I had to pick one. And everything in yellow is obligations against you that are hurting you. And it's too much to go through. But this is what your obligations boil down to. I understand and agree that if I meet all of the qualifications for recertification, my certificate will be valid for 10 years, contingent upon my timely satisfaction of all requirements of the American Board of Pathology Maintenance of Certification Program. They can pull it whenever they want. It's theirs. They only loan you the certificate. They don't sell it outright. They only loan it to you. You belong to them. And if you continue to subscribe to this fallacy, then I think I'm not going to do it. That's all I can say. And I agree to be legally bound. As Dr. Crispin said, doctors have gone to court. Remember the one test question and give it to us for our recertification training product. Over 100 physicians, they took their board certificates away. Some of them got fined. Some of them, the one woman that he mentioned, you can't find her. I think she might have committed suicide. She's off the list. And I'll go back to what he was saying. This is the Godfather. Make him an offer he can't refuse. Ken said that earlier. I'll say it again. If you were on the streets of New York and the mafia were there, at least they were honest. They told you pay, we won't bother you. But here, the ABMS, they're telling you to pay, and you can never really be sure they won't come back and bother you because they might change the program and suddenly a promise, it was only a promise. I mean, after all, it's only a certificate. And with that, I want to show you too, I got this letter recently, I kind of laughed it off, but I'm going to show it to you. If you wish to register for the exam, The fee is $2,100 for an anesthesiologist. So, I mean, that's just the exam, and it already covers the sum that the ABIM was quoting. And I like this part. You know, if you read this, this message contains confidential information. If you're the wrong person, then destroy this email and refrain from disclosure, copying, distribution, or use of this information because you might make somebody mad, okay? And I want to finish up. As a member of the, because I have 2 minutes, as a member of the American Society of Anesthesiologists, we have a closed claims project. And it's, they work with the insurance industry, and any litigation closed claim that's filed and is resolved goes into this file, and it's existed for about 3.5 decades. And so, going back to board certification, I asked them, well, can you look from 1990 to 1999 and ask the question about lawsuits against certified and non-board certified doctors? And, well, yeah, we can do that. And they went and they did it, and they gave me the data, and I'm going to show you what it is here. But they said, I'm not allowed to publish that because, well, for whatever reason they had. And this closed claim study, they published all kinds of articles, but this was not a good question. Just to emphasize, my National Specialty Society will do what it's obliged to do, but doesn't really want this information out there about board certification because it's a sham. It really is. And we looked at, there was no statistically difference. There was no difference at all. They gave me one set of numbers regarding the number of deaths in the claims, the permanent injuries, and this was a grading system, and the temporary and non-disabled. There was one set of numbers for the certified versus the non-certified group. Now, I went too fast, I think. Somewhere here it says that, here, 76 board certified versus 24% non-board certified rates. And that's important to recognize that 25% of all physicians in the United States never certified. And they're good docs. They're out there practicing. What's going to happen to them? Well, the FSMB will have a program for them to cha-ching their money. If you can't go to the American boards, the FSMB will take care of you just fine. And that compares to the 78 and 22% of claims analyzed. Statistically, it pairs to today's reality. That's all I wanted to say. And what you did find out is if you were board certified, the median payment was higher than the non-board certified physicians because, by Jove, you're that much better of a doctor, right? I mean, the ranges were a little different, but this says to me, board certification just might be a medical legal liability because you're supposed to know more. And let's face it, I'm an anesthesiologist. There are nurse anesthesia providers, and they never get sued anywhere near what an anesthesiologist would because, well, they don't know as much, I guess. And so this is just, I'm presenting this data because I'm not allowed to publish it, but I'm allowed to speak in Ohio because it was pertinent to the MOL MOC issue, and that's why we're here today, and I share that with you as such. And with that, I will thank you very much.